Okay. Welcome, gentlemen, to our first of 2024 St. Paul Speaker Series. Our guest today is Dr. Sompwe Mwansa, who's an anesthesiologist and critical care consultant for adults and pediatrics. She's also the president for the Society of Anesthetists in Zambia and a global surgery advocate. She's been the president for the Society of Anesthetists in Zambia since December 2023. In addition to all that, she's a fellow at the University Teaching Hospital, where she's worked since November 2022. Before that, she was the Secretary General for the Society of Anesthetists in Zambia for quite a while, for 2 years. And before that, she was an anesthesiologist and critical care specialist at Indora Teaching Hospital in the Copper Belt for a year, or for almost 2 years, actually. Prior to that, she was back at UTH as a medical officer in the Department of Anesthesia and Critical Care, and has also worked at Ron Antelope General Hospital in Mwansa in the Copper Belt and at Quito Central Hospital. So she'll be talking to us about surgery and anesthesia service provision in Zambia. So, Doctor, what we have here is a group of alumni from St. Paul Secondary School, which is in Mulungushi in Kabwe. We do this every month, the last Friday of each month, and we use these programs to basically get new knowledge about what's going on in the country, to do some networking, and to improve ourselves as men and family men, and just to learn how we can be better. So health is important to us. The economy is important to us. Income generating activities are important to us. Understanding the laws, the policies from the government is important to us. So we do a whole lot. And then at the end of the day, we just like to be, in companionship with one another. So you're really most welcome today, and we appreciate your time and your expertise, and we're just waiting to hear what you have to say. So please take it over.
Okay. Thank you so much. I hope my network is a bit more stable now. But thank you very much, Prof, for inviting me this afternoon. It really is an honor and a pleasure to get to speaking to people who have an interest in what's happening in what's happening in our country. So this afternoon, we will be chatting a little bit about some of the challenges we have in anesthesia service provision here in Zambia. And I think that you'll find that a lot of what we have to speak about speaks also broadly to the surgical system in Zambia, which for some time really has been in the background and hasn't received as much attention as the infectious diseases, or so we call them. An example I can give is that right now we're in the middle of a cholera outbreak. And as a result of that, there has had to be scaling back of certain theater services and anesthesia services to make way for that. So it's something that it's a system that often gets pushed to the background. And as a result of that, we see some of the challenges that result in that. So we classify the challenges to achieving a safe anesthetic service in 3 broad categories for us as a nation. And the first of that being human resources challenges, then equipment and infrastructure, and also a data challenges. I'm going to go through these in a bit more detail, so I'm not going to spend much time laboring on the text that's underneath those. But if we begin with the human resource challenges, I think that one of the things that is important for us to remember is that the backbone of any healthcare system is its human resource capacity. And when we don't have enough human resource human resource capabilities in order to meet a need, that's where we start to really see cracks occurring. As far as anesthesia service provision goes, we have quite a severe scarcity of physician anesthetists or anesthesiologists such as myself. Now, the WHO had come up with a number where they suggest that you should have roughly about 5 anesthesiologists per 100,000 of the population. in order to ensure the safe provision of services. And this number translates to about 950 given Zambia's population today. And this number is in addition to the non-physician anesthesia providers. So people who are trained like clinical officers or nurse anesthetists who may not have had the initial training in medicine before going on to specialize. So as I said, Zambia as a nation today needs about 950 anesthesiologists, and we're currently less than 50 physician anesthetists or anesthesiologists in the country. And this poses a huge barrier in ensuring that safe anesthetic services are provided across the nation. Looking at the distribution, you can see that quite a large proportion are located in Lusaka. We only have one physician anesthetist or anesthesiologist in Southern Province, and we have 8 on the Copper Belt. As much as we have so many being concentrated in Lusaka, I think that it is important to emphasize that they still are not enough to meet the capacity and the number of patients that they're attending to in order to keep services moving smoothly. In terms of the qualifications or the sub-qualifications of anesthesiologists, we have one who is specialized in regional anesthesia, one who is specialized in obstetric anesthesia, 2 who are specialized in cardiac anesthesia, 5 who are specialized in pediatric anesthesia, and 27 who are considered general anesthesiologists. So this essentially speaks to the numbers that we have serving the population. And I would like to just particularly call your attention to the number of pediatric anesthesiologists, there being 5, of which I am one, serving a population of about 8 or 9 million children. As you can see, that this really skews accessibility for children, particularly those who are in rural areas. But I mean, even if we talk about obstetric anesthesia or general anesthesiology, the people who can access it more are those who are likely to be on the Copper Belts near an urban setup than those who are out in the peripheries. So the impact that this has on healthcare delivery is that majority of anesthetic services are provided by non-physician anesthesia providers. And while they are doing a great job of trying to keep the system afloat, they have to work without adequate support and supervision. Because I have a background of medicine and then I moved on to do my master's in anesthesia and the fellowship in pediatric anesthesiology, there are certain nuances in treatment plans that I can understand that a non-physician anesthetic provider may not be able to fully grasp. And because there aren't enough physician anesthesiologists available, they are forced to navigate those territories with sometimes very sick patients without the support that they need. And this will contribute to challenges in providing the best care that we can, even though, as I said, they are really doing the best that they can, but we need to do more to support them as service providers. Equipment and infrastructure challenges are something that happen across the board. It's been a lot of our major hospitals were built in the 60s and 70s, and a lot of them have not undergone any major renovations since that time. It is rather unfortunate. And also the procurement of equipment has not kept up with development, has not kept up with innovation, has not kept up with our patient population needs. And so you find that a lot of the equipment that is being used is obsolete or should have been commissioned out of service, but because that is what is available, then that is what we continue to use now. So this really just speaks to the challenges that the infrastructure challenges that we face in providing safe anesthetic services. And it speaks to everything like the theater setup. Do we have adequate number of theaters? Do we have appropriate spaces to recover our patients? Do we have a proper patient flow through our theaters? Is our equipment in working order? And do we have enough equipment to train those who need to be trained and to develop skills in those people who need to have that skill development? One of the things that is imperative to the society as of now is supporting postgraduate training in the country. We are fortunate that we are able to train anesthesiologists in Zambia, but it requires a lot of support to the academic programs. And this can be things like mannequins to run simulations or iPads or things like that. And a lot of our training equipment is quite expensive. So how do we position ourselves, especially particularly as the Society of Anesthesiologists of Zambia, being that we are so small and we're so few, how do we position ourselves into a place where we can acquire some of that equipment so that we provide appropriate support to the training programs in the country? The final challenge to providing safe anesthetic services in the country is what I like to call the data challenge. Unfortunately, there's a significant scarcity of data that is related to key performance indicators that would allow me to inform my practice as an anesthetic provider. And sometimes you may find that it really is because we don't have a platform through which to collect that data, or we just don't have a functional system or network that we can use. Collecting data should be easier in this day and age because most anesthetic providers do have access to smartphones, but things like setting up an app or running an app and the program and the maintenance, all of those things come with cost. And so we as a particularly small society find ourselves in a position where we are not really able to collect that data that we can then use to lobby for certain policies or influence certain decisions being made, particularly at higher level. I will say there has been fair engagement with ministry, but as I said, it's often difficult when you don't have enough of the data that you need to make a case for certain things that will support that data. So some of the key performance indicators that interest me, particularly as an anesthesiologist, are what we term critical incidents that happen in theater, unplanned admissions to the intensive care unit, and things like 30-day mortality. Zambia is in a position where anesthesiologists who train in this country have what we call a dual qualification. So not only do we work in theater, but our degree is a Master of Medicine in Anesthesia and Critical Care. So we also work in ICU. And so because of that, we have to essentially man both spaces. And this sort of feeds back into the human resource challenge again, because when there are so few of us, then how are we shared as a resource to ensure that certain theaters keep running whilst ICU is also functional? This becomes very important, as well as trying to attract as many young doctors as possible into the profession and to specialize into in anesthesia. So some of the solutions that we are thinking through and trying to work through as a society to meet these challenges, it's not enough, or it's never enough to simply state your challenges. It's always important to take it a step further to begin to look at solutions to some of these challenges. So with regards to the data challenge, as a society, we are working through developing and piloting what is known as a critical incident reporting tool, which will be a completely anonymous tool that all anesthetic providers can fill in. And the idea is that this will give us an idea of where there are lapses in knowledge and skill so that we know how to develop programs to support continuous medical education for anesthetic providers. With regard to human resources, this is really a very complex and multifaceted challenge. And so, of course, the solution is going to be equally complex and involve a lot of different players. But one of the things that we are pushing for, and we have been pushing for a number of years, is the introduction of retention initiatives, as well as increasing the number of available residency and consultancy positions. I think that when we're looking at our numbers of 50 versus 950, it becomes very apparent that we are sort of in a crisis situation with anesthesiologists. And so more focus really needs to be put on the anesthetic fraternity and how we can develop it. And finally, with regards to equipment and infrastructure, is of course we are advocating for more significant investment in developing the anesthetic infrastructure, if you will. So there needs to be upgrading of the older theaters. There needs to be procurement of appropriate anesthetic equipment that is in keeping with a lot of the innovations that are happening in the world of anesthesia and shaping how we are able to provide anesthesia for our patients. An example that I can give is the more recent advances in regional anesthesia. We only have one regional anesthesia specialist in the country, but regional anesthesia is a type of anesthesia that allows us to just completely anesthetize the part of the body that's being worked on. If it's the hand, if it's the arm, if it's the leg, that part is completely anesthetized, and the rest of the body is normal, if you will. And this has a lot of benefits that we're seeing, and it allows us to treat a wider variety and a wider scope of patients. But the initial investment can be quite costly because you need to buy an ultrasound machine and you need to buy special types of needles and those sort of things. So pushing for that and advocating for that is something that we are really pushing for to try and understand as well the cost and benefit of having a regional anesthesia service in Zambia. So with those few remarks, I hope I've been able to just give a very broad overview of some of the challenges that we're facing, both as a society and as anesthetic practitioners in Zambia. And it is my privilege to have spent this time with you on behalf of the society. I'm really honored and I am very much grateful. Prof, I end here.
Thank you, Doc. So are you ready for some questions?
Yes, absolutely.
Okay. Well, thank you so much. This was an excellent presentation. I really loved it. And I've learned a lot myself about this practice that normally we most of us that are not in the medical field, we don't really know what role you guys do apart from, as Gandiza said in the beginning, making people immobile for surgery and, in theater and stuff like that. So people are free to ask questions, by raising their hands or just shouting out and then asking Dr. Sompwe Mwansa a question. I would like to ask some questions myself.
Yes, please.
Yes. So, yeah, I'm really sorry that, there's so few of you in this very important and critically needed, part of medicine. But why there are so few of you? We've been training doctors for a long time in Zambia. Why are there so few people taking up anesthesia? Yeah.
So the challenge with anesthesia is, I think, twofold. And I would say that I think broadly for the specialist medical fraternity in Zambia, the first challenge was, I think, in the late 90s, we lost a lot of doctors who emigrated out of the country. And there were quite a few specialists who went out as well. And we've been struggling to recover from that loss of expertise, I think, over the last few years, because it's been about 20, almost getting to 30 years now since that happened. But secondly, with regards to anesthesia, we've only been training anesthesiologists locally for about 12 years. now. So we haven't been training anesthesiologists for as long as we've been training our surgical colleagues. And I think that's really showing in the numbers. But again, on top of that, even though we have the potential to train locally, there also needs to be a concerted push from ministry as well to ensure that we have the numbers that we need. Like I said, unfortunately, anesthesia falls very much under our surgical systems, and surgical systems tend to be overlooked when there is malaria, TB, HIV, cholera, and typhoid, which are always surging, and even COVID as well. So you find that what tends to happen is that we are overlooked as a component of medicine. And I would say perioperative services really, because it's not just anesthesiologists who are struggling. Even colleagues in surgery, in obstetrics, orthopedics, neurosurgery will say the same thing. We as a country have only managed to produce 7 neurosurgeons for 20 million people, for almost 20 million people. So there really needs to be a concerted and intentional push, I feel, in terms of priority setting that will allow us to really flourish and get the numbers that we need.
Perfect. Thank you so much. Chalo, you have a question?
Yes, and sorry I showed up late. It's 5:30 over here. And you might have mentioned this in the beginning, so if I did, please let me in the back of the head and let me know. One of the challenges that I've seen or experienced, not personally, but with a close family member, was just the I don't know what the procedure is for administration of anesthesia in Zambia, because I've heard of, or I've witnessed a couple of cases where people have actually died because either the anesthesiologist forgot to administer anesthesia, or the anesthesia administered was inadequate. What measures are in place currently to instill confidence in the public that this practice has what I would class as a fail-safe mechanism to make sure that such cases don't happen? I mean, granted, mistakes will happen anywhere in the world, but I think, unfortunately, when you see 2 cases of family members die because of seemingly a simple thing like this, it makes you wonder if there are systems in place or a checkbox where, everybody in the operating theater understands and knows their job, and the measures to check that each and every person did their job before somebody's cut open. Thank you.
Okay. First of all, allow me to extend my condolences for the losses that you experienced in your family. I really am somebody who truly believes that a death on the table is really one of the one of the gravest incidents that can occur in anesthesia. It's something that can occur in medicine, as far as I'm concerned. Speaking to having systems in place, I think that you'll find that unfortunately disparities exist in how cases are managed and how cases flow. So I can honestly say that having worked at university teaching hospitals or teaching hospitals, I can say there are certain steps that we go through, checklists that we go through, that before we start, we all understand what our roles are. We are sure that our machinery is working, and drugs and any concerns that anybody may have about the patient are voiced out. Unfortunately, that practice is not uniform, particularly when you go to what we would say the lower levels of hospitals. So like at a general hospital, at a district hospital, depending on who is providing the anesthetic. Anesthesiologists will tend to be focused at the tertiary level hospitals. So the teaching hospitals or National Heart Hospital is where you will typically find anesthesiologists. But at general hospitals, at district hospitals, you'll often find non-physician anesthetists, and they may not have the support that they need. They may not know who to ask if they're uncertain about the patient and things like that. And that is why the critical incident reporting tool becomes so important, because then it also gives us the data that we need and the knowledge that we need to inform the policymakers to say, this is where we need to focus. This is where we need to shine a spotlight on, that people may not have appropriate knowledge for instance, certain types of drugs or anesthetic techniques. And this is why we're seeing certain outcomes. So it becomes very important for us to have that data, and that is part of the drive for the society for this, I would say, this quarter, to get the critical incident reporting tool out, but also to push for having appropriate KPI data being collected.
Thank you so
Thank
much.
you very much for that information. And just maybe as a follow-up based on what you've said. Now, you know, operating on people is not like operating on a car, right? I can make a mistake on a car and nobody dies. And we could fix it somehow. A person, you know, pretty much zero room for error, if you will, right? So seeing that there are those gaps in maybe expertise or knowledge, shouldn't there be at least at the very least, a minimum standard? Maybe any person that's even at the lower level hospital that's involved in any type of anesthesia administration has some basic qualifications, maybe through your society, where you have basic minimums. You have to be certified by our society before you can work on a person. Now, I don't know if that standard exists, but I think if it doesn't, there's obviously room for, it's a low-hanging fruit, right? Versus, I mean, granted, you can't train everybody to be this, but at the very minimum, you have to be able to do A, B, C, D for you to qualify to do this job. Yeah. Thank you.
That standard does exist. The standard does exist both with Health Professions Council, with ministry, and of course with us as a society. We do have guidelines and we do have a hierarchy, if I could call it that, of anesthetic providers and different levels of anesthetic providers. The challenge that we have with a lot of anesthetic providers is continuous professional development or continuous medical education. For myself as an anesthesiologist working in a tertiary hospital, I'm going to be exposed to a wide variety of cases, and I'm going to be exposed to patients with a wide variety of conditions. So I'm going to exercise a wider variety of skill. Whereas my colleagues who are working in rural areas may only see 3 or 4 types of procedures. And that means that their reservoir of knowledge and skill will become depleted if they're not continuously engaging in continuous medical education, continuous professional development. Unfortunately, there exists a sort of tug of war at that hospital level when these officers will ask to say, look, there's a workshop happening, there's a conference happening, can I attend? Because then the question is, if you leave out of station, who's going to provide anesthesia for you? And so you find that what happens is that a lot of institutions only have one anesthetic provider, and this is somebody who, for all intents and purposes, doesn't get a break, never goes on leave. Now, one of the things we are trying to do to address that deficit as the society is using platforms like Zoom to run webinar series. It's something that we launched last year, and it's something that we're continuing this year. And we're right now in the middle of a cholera management webinar series because there is some overlap with critical care and cholera patients. And so that's one of the ways we're trying to ensure that we maintain that standard and that anesthesia providers maintain that knowledge and maybe some of that skill. And then, of course, we need to actively engage and actively lobby for officers to be released to attend refresher courses and workshops and conferences, because that is where learning takes place. That's where skill sharing takes place as well. And also one of the final things that we are doing in collaboration with the society, the Surgical Society of Zambia, I beg your pardon, and other societies, is having outreaches to the more rural areas so that we can actually work with them, mentor them, and in their environment and in their setting, do skill sharing and knowledge sharing.
Thank you so much. Gentlemen, anybody else has a question? Mr. Gandize, you've been trying to speak for a while. Go ahead.
Yeah. I don't know if my question, I hope that my question will be answered. Sure, one of the reasons why we have this fora is that we, as you said, that the introductory remarks, that we have some kind of network and the connections in the cases where we have a number of ailments that needs surgical attention and anesthesia. And I would like to ask the doctor, I've got a peculiar case myself, and a number of times I've gone to hospital. I've got a lipoma, and I've, for the past 10, 12 years, I've wanted it to be removed. Twice I've gone to UTH, and the other day I was requested to go in my naked uniform and wait on the bed for almost the whole day, from 07, and I was hungry. I was told tomorrow 7 hours don't eat anything, and then I went without eating, and for whole day I was kept waiting. At 16 hours, doctors came and just said, no, today we are not attending to cases such as yours. And that got me frustrated, and ever since that day I've never gone there. But the staff is with me, and sometimes it gives me some pains around the neck. The other time when I went there, I was told no. The doctors who are attending to me say, no, if you want, you look for money, we'll attend it from Hilltop or from this private hospital, and I don't have money. So I just reached a deadlock, an end dead, where I don't know what's next. Do you have a fora where perhaps around the country or provincial offices, people could be submitting their situations in which needs whether minor or major surgeries, so that you have data, and with that data, then you begin to talk to the Ministry of Health and those in government, so that such cases can be attended to without necessarily being referred to private hospitals each time you want to have something attended to. It means then, when you don't have money, it means you are just going to suffer. And sometimes when you go to the hospital, you'll be given an appointment more like 5, 6 months ahead of you.
Yeah.
When it's something that may need attention immediately. So I don't know. So we could do, perhaps with your linkages, we could try to identify where we can possibly go and seek help, and so that we have some of these things attended. I don't know if my concern is heard. Thank you.
Yes, it has been heard, and it is a very, very valid concern. Remember, I spoke about our surgical system not having received the attention that it needs. In 2017, the ministry actually released some data speaking to situations such as yours. And they found that almost 75% of patients at the time who needed surgery actually didn't get it. And it's not because we don't want to offer the surgery. It goes back very much to our surgical system not having the capacity to treat everyone that we need to treat. Of course, I would encourage that we get to hear stories like yours, because I don't think that number has remained the same. The population has grown and people's needs have grown over time as well. And I feel like we need to have a clear picture to understand that with the surgical system as it is today in 2024, how many of our patients are we able to serve? Have there been any improvements? How do we improve our surgical system and how do we improve its capacity? I think that it's very telling that minor procedures cannot be performed or have not been performed for over 10 years because we don't have a system that is able to provide the service that you need in good time. So I think it's definitely something that we would want to know and something that we would want to hear about, so that as we are having those engagements at that level, we can still speak to some of the information coming through to say, look, our surgical system is still not where it needs to be, because these are the experiences and these are the lived experiences of people out there.
Thank you so much, Mr. Gandizo. That's a very important question, and hopefully, going forward, we can, get more specific officers to, to attend to you, and I'm sure Dr. Mwansa could help with that as well. Just pointing us in the right direction with a number or email or an address.
Yeah. I think it will be helpful so that we get in touch with the doctors or surgeons that can attend to us, and maybe also provide what is the cost range, so that maybe a service that is affordable can be sought.
Okay.
Thank you.
I would also recommend, if you are with NEMA, there are facilities such as Mainasoko, which do accept NEMA. And so you could have your surgery and be seen from there as well if you are in the Lusaka area.
Okay, thank you very much, Doc.
Okay. Well, Dr. Mwansa, I had a question. I always have too many questions, but I'll start with this one first. So we have a deficit of about 1,000 people in the anesthesia provision. So explain to us, like, what did it take to fill that gap? Because we are 50, we need 950 more. What would it take to fill that gap? Because, for example, like yourself, you had to go through medical school and do a master's and then specialize. That takes like 12 years just to get to where you are in terms of schooling. But how do we get more of you that go to school for such a long time, but we scale up? I mean, how does that happen? Just please explain to us how we can achieve that.
I think that one of the things we need to take advantage of are the numbers of medical doctors being produced in Zambia. We have quite a few. I believe we have upwards of 7 private and public medical in this country. And collectively, they are producing somewhere in the region of 1,000 doctors per year. And I know that we don't have the ability to train 50 or even 100 anesthetists per year. If we could at NDOLA, TH, and if we could target 10 anesthesiologists per year, then that means that we're producing 30 anesthesiologists per year, and scaling up, because the more anesthesiologists we produce, the more become available to train. Therefore, the larger our training capacity becomes. It also means that there needs to be increased commitment from institutions like University of Zambia. University of Zambia, to this day, does not have a standalone department of anesthesia. And it's something that we are pushing for as a society, because if they have a standalone department, then they are obligated to hire more than just the one anesthesiologist currently on staff. And as they build their faculty in the Department of Anesthesia, then they build their capacity to train more. And so what happens is that we would see more of an exponential increase in the number of anesthesiologists as opposed to a linear increase.
Yeah. Okay, I think we have our marching orders here from Dr. Mwansa. We know what to do now, just to raise money and make sure these programs are built into the curriculum in those medical schools, right?
Mm-hmm.
Yeah, I don't know if anybody else has another question, but I could ask another one. So you spoke about collection of data from different places, and I'm assuming some of this data could be electronic information. Have you
Yes.
partnered with Smart Zambia?
We've been trying to partner with the Smart Zambia initiative to try and see if we can use that tool for collection. What we're hoping to do is start on the Copper Belt to see if we can use that maybe at Ndola Kitwe Teaching Hospital, and see how the pilots, or use those as pilot sites, see how it would work. And then from there, expand to the entire province. And then from there, once we've worked out the glitches, float it then on a national level. Fortunately, we do have quite a bit of support from the senior medical superintendent in Ndola and in Kitwe, as well as the PhD. So it's something that we're hoping, as I said, by the end of this quarter, if we can have our critical incident tool running, so that we start to collect some of that data.
Oh, perfect. Yeah, because the gentleman that runs Smart Zambia is actually one of us from this alumni group.
Okay.
I'll give you his contact information just in case you need to use their platform, because they do have they have people all over the place that are collecting data. So if you give them a data collection instrument, maybe they could do it for you, or they could provide some financing or something. But I mean, their main objective is to collect data on behalf of public services. So you absolutely qualify for that service. Yeah. So where is your society located?
So our society is located in Lusaka. Our offices are located under the ZMA Secretariat, Zambia Medical Association Secretariat. However, I, being present, I'm currently on the Copper Belt. I am back having completed my fellowship. So I am in Ndola, and the executive are mostly in Lusaka. Some are at Manasoko Military Hospital, some at Levi Mwansa University Teaching Hospital, and some at University Teaching Hospital.
Fantastic. Okay. Well, we're coming up to 1 hour of the program. Do you guys have any more questions for Dr. Mwansa? Okay, I'll ask one last one.
Sure.
So you had 3 challenges, and of course, you've spoken about the type of solutions that you have. One of the challenges was infrastructure, which you have not really explained about what the solutions might be. You've spoken about human resources and data, but the infrastructure aspect, what would it take in terms of infrastructure to have anesthesia service at level 1 hospital in Mwansa or Mazabuka or places like that?
The unfortunate answer to the question is that it would take a lot of money. Okay. Anesthesia services and ICU services are some of the most expensive services in a hospital. We really do use up quite a lot of money. The drugs that we use can be very expensive. The equipment that we use can be very expensive, especially initially. But I think that one of the things we need to be aware of as well is that the cost of doing business in Zambia is quite high. And so even those who are providing equipment in Zambia their costing tends to be quite high because of the duty, the taxes, shipping. Being a landlocked country, we don't have any ports, and a lot of anesthetic equipment is quite heavy, so it has to come by ship. We can't use air freight for a lot of this equipment. So all of those charges and all of those costs sort of add up, and they make it quite expensive. But I think that even then, it has been shown that providing adequate, safe anesthesia and surgical services is actually cost effective. When you look at the expenditure that it's going to, the expenditure lost because of people not being able to go to work or people suffering from disability, in the bigger, or I would say macroeconomic picture, you find that buying that expensive anesthetic, that seemingly expensive anesthetic machine, in the long run actually works out to be more cost effective for us as a nation. You know, but I think that it also requires a lot of engagement with us, the end users. I would say as society, we essentially represent the end users. A lot of times you may find that the anesthetic machine that is suitable for a teaching hospital is really far too advanced for Mazabuka or Mwansa or Mbala. They need something which has different specifications and something more suited to the level of anesthetic provider there. And so those are some of the challenge or some of the conversations that we need to have with regard to our infrastructure, upgrading infrastructure, and procuring the appropriate type of equipment for our population.
Okay, Mr. Petain has a question. Thank you, Doc, for that answer. Mr. Petain, please go ahead.
Yes, Professor. My question goes to Doctor, or maybe may I not say a question, but a suggestion.
Yes, please.
She mentioned that the teaching hospitals do have that session, but the problem is with the district hospitals. I know we have 116 districts in the country, and of course, if we had to tackle all of them and ensure that they have that session, it would be very difficult. But why not do it in a phased approach, but determined to ensure that instead of just being at the teaching hospitals, we start moving towards these district hospitals. We can target 5 in a year or even 3 in a year as we do our expansion program, so that we have movement. Because when you see the road is too far, but you don't take any step, it means you will never go anywhere. But when the road is far, you take a step at a time. At one point, we expect to reach somewhere. I hear those of us who have been following the group, at some point, people are talking about why are people being evacuated, taken elsewhere. And that kind of treatment or approach to people who need treatment favors those who have money, those who are known. But the poor majority of the taxpayers do not have access to such services. So I think, Doc, we should come up with a program or an approach that is targeting, at least in a year, we say, every year we are targeting 3 to 4 hospitals that can be upgraded. And then we engage with the government to ensure that they also have in providing the necessary resources. How do you think about that? Thank you.
I'm just adding to what my brother Petain has said. Do you, on your programs for fundraising, and also, do you have any proposals, technical proposals that have been written with a situation analysis of the situation of the service in Zambia, where 1, 2 proposals have been submitted to donors, and with the network that may the association have, which you have said, okay, we have submitted 3 out of this, nothing was funded?
So first of all, I just wanted to first appreciate the contribution that was given. Of course, a staggered approach is going to be the only way that we're going to catch up to and build with the growth of the population. Secondly, with regards to proposals that have written, we have submitted, majority of the proposals that we have submitted and applications that we have done have been for training, and a number of those have been successful in terms of the workshops and things that we've done. The society does provide what we call safe anesthesia through education workshops for obstetric anesthesia and pediatric anesthesia, and these are the proposals that typically have been funded. However, they're not funded locally. Funding tends to come internationally through the UK government or through the World Federation of Societies of Anesthesiology and other such partners. Locally, we are starting to work on a proposal to develop what is called like a trauma center along the line of hotspots. So I'm sure many of you have heard the news or often hear the news that along the road between Ndola and Lusaka, there tend to be quite a few accidents there. And so coming out of a meeting that we had as a Society of Anesthesiologists of Zambia, with we engaged RATSA, NEMA, we had Ministry of Finance there as well, and different other societies. We are now in the process of working on a proposal to see how we can upgrade one of the hospitals, one of the smaller hospitals along that line, and make it essentially a trauma center where we can stabilize patients before dispatching them for specialist care.
Wait, what are you saying? That's too hard. It's too hard?
Yeah, so yeah, doctor, that's a very good approach that you guys are taking. Actually, we've been very worried about the state of the road, you know, between Lusaka and the Copper Belt, and can't wait for the complete dual carriageway to be built, so we reduce the number of accidents, because they're very horrific. You know, when they happen, it's a yeah, multiple fatalities, and it's not pleasant to see. But I know you're very busy, and you know, you have other people to attend to, being one of the 5 you know, specialists in anesthesia. What is your specialization again? Not regional.
Pediatric.
Pediatric, okay. Yeah. So
Yes.
are you in the ward right now? Are you with the little kids?
No, no, I had to step out of theater. I was in theater this morning until about 13 hours. And then there was another meeting, like I said, the cholera management series that we're doing. We had that at 14 hours, and then I had this engagement.
Oh, I see. Well, thank you so much for making time for us. And yeah, we all realize you're very busy. You know, you're a critically needed person in the medical sphere. I'm so sorry that there's so few of you, and I didn't realize there were so few of you, because you know, it's one of those things, like if you don't need it at that point, you don't really pay attention.
Yes,
but
absolutely.
it seems like under your leadership, the society has gained a lot of what can I say? Like you know, people are noticing what you're doing. I, for example, found you on LinkedIn, and you know, I've been following what you've been doing, both locally in Zambia and overseas, and it's pretty impressive that you know, you have such you know, talents to be a good leader and bring people along.
Thank you so much.
Yeah, bring people along to follow your vision. I personally am very touched by what's going on with the state of anesthesia in the country, and I've taken the 3 points to heart, you know, the data, the HR, and the infrastructure. And maybe when I'm talking to people that might want to listen, I'll mention them, you know, and give them your contacts. So
thank you so much. I would appreciate that.
Absolutely. So I guess without anything being added, we're going to close this meeting. Moses, you came very late, just when we're ending. But you can say hello to Dr. Mwansa if you like.
Be grateful for the love.
And Bwambo, you want to say hello to Dr. Mwansa?
Don't make me disappointed like your mother did to me.
He's not going to do it.
Hello,
So,
Doc. Have a good day.
Good afternoon. Thank you so much.
Doctor. Sorry, I joined the meeting very late. But how are you?
I'm well, thank you. How are you?
I'm well, thank you.
For
Are
me,
you
really,
ready
Doc,
to
I didn't
record?
expect my call. Once the contact line is there, I really need the advice for my situation to be attended to.
Of course, sure.
Okay. Okay. So Dr. Mwansa, so much appreciate your time and your your generosity towards us and your expertise towards the country and what you're doing. And we just hope you continue the good work and get some more, people under you and train as many as you can.
Yes.
We'll
Thank
definitely
you
be in
so much.
touch. Absolutely.
Yes.
I'm going to send you this video of the recording, and I'll also send it to my colleagues who couldn't make it, so that a lot of
Okay.
us have your information.
All
So
right. Thank you very much.
thank you. Have a good day.
All right. You too. Bye.
Yeah, bye-bye.